So if we summarize the whole thing, Sjogren's is seen in women, female is to male, 9:1, middle-aged women, and also it can present in primary, secondary, associated with or non-associated with connective tissue disorders and all. So the most common glands involved is exocrine glands. So what will happen there? There will be environmental and the genetic factors which will cause formation of autoantibodies, which will lead to formation of immunocomplexes which will circulate, which can cause this lymphocytic infiltration, ductal proliferation, right? So there is proliferation of ductal epithelium which can cause dry eyes, dry mouth on the dry skin. So remember this triad: dry eyes, dry mouth, and the dry skin. So 1 2 3, right? It is associated with HLA-DR3 and anti-M3 antibody, and TH1 is more active, and the only endocrine gland which is involved is Hashimoto thyroiditis thyroid gland, right? So this is about the gist of this pathogenesis. Now coming to the clinical features: dry eyes, dry mouth, and the dry skin. So first is dry mouth. So for this you can do cylometry, xylography and all, and the important thing, the gold standard, is biopsy of this minor salivary gland, which will show you focal lymphocytic cell adenitis. Focal lymphocytic cell adenitis, right? So when you see this focal lymphocytic cell adenitis, it is indicating the risk of development into B-cell lymphoma. So what is B-cell lymphoma? There is persistent, painful, nodular, parotid enlargement, where you can see this complement pathway being decreased and this ROLA being increased, right? So extranodal marginal B-cell lymphoma. So this Sjogren's is associated with the risk of development of marginal zone B-cell lymphoma. So the treatment you give is saliva replacing agents and all. For the dry eyes, you can do shimmer test and rose Bengal staining, and the treatment you give is artificial tears. And for the systemic symptoms, the most commonly involved systemic symptoms is arthritis, jock or arthropathy. For this arthropathy, you give steroids or NSAIDs, and for CNS, fungal ataxia, ganglionopathy can be seen, and in the lungs, pneumonia, interstitial pneumonia, in the liver, primary biliary cirrhosis. So in the kidney, RTA type 1. It is important to remember in the Sjogren's, the kidney involvement lead to RTA type 1, renal tubular acidosis type 1, right? And the skin, you can see Reynolds phenomena, dry skin, urticaria, palpable purpura and all. So for the systemic symptoms, again you can give this steroids, immunosuppression agents, and also biological agents like infliximab, rituximab, INF alpha and all. And for this antibody, cevimeline. So this is about the treatment, right? And if you see other diagnostic features, obviously there will be ESR will be rising, immunoglobulins, immunocomplexes will be rising, rheumatoid factor positive. In you'll do this ANA profile, you can find anti-ROLA antibodies. So it is important to remember anti-ROLA antibodies and anti-mitochondrial antibodies, right? So this is about it. Bye.